Trainers. Good evening to our very esteemed President-elect and head of the Education Committee, Dr. Quinette Kalu. Head of the Education Committee of the NSA, Dr. Quinette Kalu. Welcome, ma. Good to have you on here. Good evening to everyone. Please put on your various groups, your residence groups, your various anesthesia departmental groups that we're about starting, because we are starting now. My name is Dr. John Afamo Semene. I am the trainee representative of the Nigerian Society of Anesthetists, and I am very pleased to welcome us all to the second residence academic series for the year 2025. Today, we are discussing sepsis, current management guidelines, and I'll be introducing the moderator for the day, who would tell us the housekeeping rules, give us our general rules, and will introduce the presenter. So it's my pleasure to call up Dr. Ruben Mke. I hope I pronounced that correctly. He's a registrar in the University of Benin Teaching Hospital and will be moderating today's session. Dr. Ruben, how are you? Are you here?
Yes, I'm here. Thank you very much, sir. It's a privilege actually to be here and moderating. And yes, you got the pronunciation correct, sir. My name is Dr. Mk Ruben, Registrar, University of Benin Teaching Hospital, Department of Anesthesia. I'll be one of the moderators today for this discussion, together with my senior colleague, who will be the senior moderator, Dr. Anyate Ebo. So, all of you, welcome everyone to today's session of the discussion. Before we continue, I would like to remind all of us of our housekeeping rules. That's, we should all try to rename our devices so that our names will be reflecting once we are logged in, because those are the names we'll be using for our attendance. And then I also like to advise all of us to mute our devices throughout the course of the presentation. And at any point during the presentation, if you have a question, you can conveniently type it into the chat box. At the end of the presentation, we will collate all the questions and they will be asked to our presenter. And then also at the end of the presentation, if you would like to ask your question by yourself, you can just raise your electronic hand and you'll be granted permission to do that. So without further ado, I would like to call on our presenter for today to commence the presentation. You have a total of 30 minutes for the presentation and then 5 minutes for the introductions. So we'll be working with time throughout the course of this session. Thank you, everyone, and welcome once again.
Thank you very much, Dr. Rubin. I am Dr. Basim Fonodo, Senior Registrar of the Department of Anesthesia from the University of Benin Teaching Hospital. And today we'll be talking on sepsis, current management guidelines. We want to talk on this using the following outline. We'll introduce, define the terms, look at the epidemiology, up to the conclusion. And as a way of introduction, the word sepsis was derived from the ancient Greek word for rotten flesh and putrefaction. It is said that without using the term, the Greek physician Hippocrates was the first to describe this clinical cause of septic shock. And he suggested this when he said that when continuing fever is present, it is dangerous if the outer parts are cold, but the inner parts are burning hot. Sepsis is a common life-threatening infectious illness that is not readily recognized. It has poorer outcomes in low and middle income countries because of the deficient healthcare and infection prevention plan. And also there is high management cost in the low and middle income country which will also suggest why the outcomes there are poorer. It is the body's response to infection, and the body injures its own tissues and its organ, which leads to shock, multiple organ failure, disability, and death. There are definitions in sepsis, and we want to look at the progression of these definitions. In 1992, there was a consensus statement by the American College of Chest Physicians and the Society of Critical Care Medicine that stated that there is a continuum from infection, sepsis, sepsis shock, severe sepsis rather, and septic shock. And they defined sepsis then as a systemic response to infection with the presence of 2 or more SIRS criteria, that is systemic inflammatory response criteria. And dysfunction and septic with more than 2 persisting best adequate fluid resource. Systemic inflammatory response syndrome is characterized by the presence of 2 or more of temperature greater than 38.0 or less than 36.0, heart rate greater than 90 beats per minute, tachypnea with respiratory rate greater than 20 cycles per minute, or when we have the tension of arterial carbon dioxide less than 4.3 pascals, or its equivalent of 32 millimeters of mercury, total white blood cell counts that is more than 12 billion or less than 4 billion, or when there are more than 10% of the immature neutrophils or the band forms. In 2001, the definition was revised in what was known as the Sepsis 2, and it was revised and updated with laboratory and clinical variables. Earlier, the definition had mentioned that sepsis is equal to infection with systemic inflammatory response syndrome. But in the 2001 definition, 2 or more criteria of the systemic inflammatory response syndrome was needed, with the presence of suspicion of infection or when there are inflammatory mediators, like if the C-reactive protein, serum procalcitonin, are more than 2 times from baseline, or when there is hemodynamic dysfunction, patients with hypotension, patients that have systolic blood pressure of up to 40, a drop in the systolic blood pressure of up to 40 millimeters of mercury from baseline, or organ dysfunction, and even when there were tissue perfusion variables, where we have delayed capillary refill or increase in the serum lactate. Together, this formed the diagnostic criteria for sepsis as defined in 2001. The European Society for the Intensive Care Medicine and the Society for Critical Care Medicine published new consensus definition in 2016, and this eliminated severe sepsis from the definition. The reason being that sepsis was severe enough to cause more than 10% mortality rate was recorded with sepsis. So that was already severe enough. Why then we will be having severe sepsis? It was just not necessary. So there was a new definition of sepsis, and also there was the organ dysfunction definition, which brought about the sequential organ failure assessment score and the quick sequential organ failure assessment score. This definition as threatening dysfunction. Definition, current definition of sepsis we are using, which is what being currently in the world. An organ dysfunction can be identified when there is an acute change in the total sequential organ failure assessment score of more than 2 due to infection. Septic shock, which is a subset of sepsis, was defined as hypotension that is not responsive to fluid resuscitation. Hypotension in this context was defined as systolic blood pressure of less than 90, diastolic less than 60, with the added requirement for vasopressors to maintain the mean arterial blood pressure greater or equal to 65 milligrams of mercury, and to maintain the serum lactate at greater than 2 millimoles per liter. The reason for this definition was because it was said that septic shock with a low blood pressure, hypotension, and increased serum lactate had a 4-fold mortality rate compared to just sepsis alone. And so it required urgent management. Immediately it is identified, treatment should be commenced immediately, just like sepsis. The new definition suggests that presumed source with SIRS criteria equals to an infection. Infection with life-threatening organ dysfunction is equal to sepsis, and sepsis that is refractory to intravenous fluid therapy is septic shock. And these new definitions were adopted by the 2016 Surviving Sepsis Campaign, which formed the basis for the international guidelines for the management of sepsis and septic shock. It was also said that in the presence of infection, that organ dysfunction should be looked out for. And multiple organ dysfunction syndrome was said to be failure in more than one organ system. The mortality rate increases with the number of organ failures. Sepsis with renal failure accounted for a mortality rate of 50 to 80%, and where 3 or more organ failures exist, the mortality rate is more than 90%. Let's look at the statistics. The global burden of the disease reported that in 2020, approximately 49 million people per year suffered from sepsis, with 11 million deaths. And this was more than the deaths that were recorded from acute coronary syndrome and cancer. Excuse me. Worldwide, it is said that someone dies from sepsis every 2.8 seconds. And half of all global sepsis cases occurred among children. This is according to a report in 2017. It is estimated that sepsis affects 0.4 to 1 in every 1,000 of population in the US and in the UK. And the advanced average age among patients are affected, especially in developed nations. Also, the increased number of invasive procedures and the wide usage of immunosuppressive drugs and chemotherapy are also factors for sepsis. There have been regional disparity in sepsis, with the incidence and mortality up to 85% in the low and middle income countries. And sepsis accounts for approximately 27% of ICU admissions in the United Kingdom, and more than 30 million people globally suffer from sepsis, with a mortality of approximately 30 to 50%. There have been paucity of studies in Nigeria regarding sepsis as a whole. Most studies have been on neonatal sepsis. However, there was a study that was done in the Jos University Teaching Hospital that showed that the in-hospital mortality was as high as 53%. The commonest comorbidity was HIV and AIDS. And it was noted from the study that the 1-hour bundle, 3-hour bundle, and the 6-hour bundle that were previously practiced were not really utilized in the study, and that accounted for the high mortality rate. What are the common sites? The respiratory tract and the pulmonary epithelium account for 43%, the urinary system 16%, the abdomen 14%, the head, usually associated with paralysis of unknown origin, 14%, and other sites 13%. Any infection, severe injury, or serious non-communicable disease can progress to sepsis. However, there are a set of people that are particularly at risk of developing sepsis. These are so the elderly and the neonates, the pregnant or the recently pregnant women, hospitalized patients, especially patients in the intensive care unit, patients with immunosuppression, HIV and AIDS, cancers, kidney disease, autoimmune disorders, and even liver cirrhosis, and patients that indulge in intense alcohol and smoking. The organisms that are associated with sepsis will include gram-positive organisms implicated in most of the cases, 65%, gram-negative organisms in 25%, and fungi are also implicated in 9%, especially in immunosuppressed or cancer patients or patients that are taking immunosuppressants or chemotherapeutic drugs. Pathogenesis of sepsis. Sepsis occurs from tissue invasion with microorganisms, and this can also occur following endothelial damage from any cause, be it infection or trauma. When these insults occur, they activate the host immune response, leading to a release of both the pro-inflammatory cytokines and the anti-inflammatory cytokines. Pro-inflammatory cytokines like tumor necrosis alpha, interleukin 6, 8, and the anti-inflammatory, they try to maintain homeostasis. However, when the pro-inflammatory are more than the anti-inflammatory, sepsis ensues. Also, the coagulation pathway is activated, and particularly the complement system, which is a vasoregulatory system, is activated, which leads to increased elaboration of nitric oxide, bradykinins, prostaglandins, triggers the coagulation cascade, leads to the release of tissue factors, thrombin, and even fibrinolysis. And these ultimately lead to impaired coagulation that is seen in sepsis and disseminated intravascular coagulation. This cascade of changes, when they are controlled, they will not progress. However, once they are left unattended to, they lead to multiple organ failure. This is a schema that represents the pathophysiology of sepsis. The insult comes from uncontrolled infection, major trauma, tissue necrosis, circulatory shock, even anaphylaxis. And this triggers the pathogen-associated molecular patterns and the danger-associated molecular patterns. And it is sensed by the protein and complex protein system that releases the complement and the coagulation system, the vascular and tissue cells, where the endothelial cells, epithelial cells, and even adipose tissues are affected, the blood and lymphatic cells, where granulocytes, lymphocytes, and macrophages are released, and there is elaboration of the complement 5A, complement 3A, and the endothelial stress response, elaboration of the endothelial leukocyte addition molecule, intercellular addition molecules, acute phase reactants, cytokines, chemokines, and cell surface markers. Ultimately, they affect the organ, the brain, the lungs, cardiovascular system, the kidney, the liver, leading to confusion, respiratory distress, shock, and other features that we see in sepsis. When the source control is effective, there is normalization of this biomarker that were abnormal before. And when the source control is ineffective, there is persistence. There is persistence, and there is multiple organ failure and death. It is important to emphasize that the endothelium of blood vessels produce nitric oxide that causes the profound vasodilation that is seen in blood vessels that results in hypovolemia, systemic hypotension that is found in septic shock. What are the clinical features? The respiratory system, there is tachypnea, cyanosis, hypoxemia, pulmonary edema. Cardiovascular system, we have increase in the heart rate, arrhythmias, dyspnea, autopnea, raised venous pressures, and hypotension requiring vasopressor agents. Hematologic system will lead to spontaneous bleeding, anemia, the rate of in the GI and psychosis and be seen in the central nervous system. So how do we diagnose sepsis? When we have these clinical features with the laboratory parameters, we take cultures before beginning antimicrobials. When we do our serum lactate assay and we have it more than 2 millimoles per liter, it's a high index of suspicion for sepsis. Can do radiology for source, like abdominal ultrasound scan, like a cranial CT scan for intracranial abscesses. Also, biomarkers that are non-specific will include the C-reactive protein, a 2-fold rise, serum amylase, up to 3-fold rise in serum amylase. When we have increased elaboration of interferon, gamma-induced protein 10, that is mainly worse in patients with respiratory tract infection and ARDS. Serum procalcitonin is also a useful marker, and recently pre-sepsin. How do we manage? The management should be multidisciplinary and should be, sepsis is managed using the Surviving Sepsis Campaign guidelines, which is a joint collaboration of the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. And this reviews the history, the Surviving Sepsis Campaign reviews history, scope, methodology of relevant literature on sepsis, and they make major recommendations for sepsis management. They were first published in 2004 with updates all through 2021, endorsed by 24 additional societies, and they apply more to the high-income countries, but they can also be applicable to the low and moderate income countries. We are made to understand that it is targeted for best practices, but clinicians' decision-making is paramount. That is the number one thing for us to follow. So this is just a history and output representation of the Surviving Sepsis Campaign guideline. And the Surviving Sepsis Campaign issues statements based on how they view a certain kind of recommendation. We have strong recommendations, or even the best practice. We have the best practice statements. We have strong recommendations. We have weak recommendations, and we have no recommendation at all. So for the strong recommended statement, it is advised that we follow through. It should have widespread adoption because it is good for performance assessment. While for the weak recommended statements, it requires consideration and shared decision making. So what are the adult guidelines that we use for the management of sepsis? They include screening and initial resuscitation, infection control, hemodynamics management, ventilation, additional therapies, and the goal of care and long-term outcomes. So sepsis is screened using screening tools, and these screening tools include the manual or automated health records, the systemic inflammatory response syndrome criteria, SIRS criteria, the vital signs and infection signs, the sequential organ failure assessment, or the quick sequential organ failure assessment, what we call the QSOFA, the National Early Warning Scores, and a modification of that, which is the Modified Early Warning Scores. So the QSOFA has 3 parameters. It looks at the respiratory rate when it's greater than 22 breaths per minute, Glasgow Coma score less than 15, and the low blood pressure when the systolic is less than 100 milliliters of mercury, and a score each is assigned. They said that once a patient has 2 out of these 3 scores, it suggests poor outcome. However, it is a strong recommendation from the Surviving Sepsis Campaign that the QSOFA alone should not be used as a screening tool. When used with other screening tools, it is more effective and more efficient in the diagnosis of sepsis. It is a screening tool that is used in the emergency units, the wards, but not in the ICU. Reason being that the patients in the ICU may already have had this with or without sepsis. The SOFA score allocates points according to pathology in 6 different organs, and an increase in the total score by 2 points indicates acute organ dysfunction, and the diagnosis of sepsis is made if an infection is identified. This is a table that shows the SOFA score, and we can see the parameters from here. A score of 0 to 4 and 6 parameters that are 6 variables that are being assessed. Early warning scores has 0 to 2. This is a table and a mode of modified early warning or 5 and Q so fast more than 2 or more if the patient is outside the eye. However, there should be a known source of infection, or there should be signs of symptoms of infection, or the patient should be at. So we use Q so far tool, or want to release the S scores. How do we resuscitate? This intervention should be initiated within 1 hour of recognition sepsis. So we had a 3-6-hour bundle before, but they've been merged into a 1-hour bundle. And the revised 1-hour bundle says we should measure the lactate level within 1 hour, repeat initial lactate if it's more than 2 millimoles per liter, obtain blood culture prior to antibiotics, administer broad spectrum antibiotics, and rapidly administer crystalloids. 30 ml per kg was initially advocated. However, because of the debates of fluid tolerance and fluid responsiveness, this should be individualized in patients. And also, we should apply vasopressors if the patient is hypotensive during or after fluid resuscitation. So fluid management, balanced crystalloid is recommended, typically lactated ringers ahead of chloride-rich crystalloid like normal saline, and it should be given within the first hour. Recommended at 30 ml per kg, and it should be completed within 3 hours. Albumin can be used in patients who have large volumes of crystalloid, and starch and gelatin are not recommended for resuscitation. What are the goals? We should reduce the capillary refill time to less than 3 seconds. The central venous pressure should be at 8 to 12 millimeters of mercury. MAP should be at least 65 millimeters of mercury. Urine output at least 0.5 ml per kilogram per hour, and we should be having decreasing lactate levels. How do we evaluate? We need laboratory investigations, including but not limited to the full blood count that may show us if the patient is anemic, or the total white blood cell count that is necessary in the SIRS criteria, or even the platelet count. Patients may be having decreasing platelet count because of sepsis. Serum electrolyte, urea, and creatinine are needed to indicate, it may help us to indicate the severity. Hyperkalemic patients may be septic, patients with metabolic acidosis may be septic, and they may also provide baseline for us to follow. Liver function tests and even D-dimers may also support diagnosis, indicate severity, and provide baseline for us. Serum lactates also may indicate the severity, and they may be used to follow therapeutic response. Arterial blood gases may show if the patient is acidotic, hypoxemic, or hypercapnic, and we will need blood cultures for aerobic, anaerobic, gram-positive, and gram-negative organisms. Also, urinalysis at the time the patient is coming in is also important, because it can tell us if there are leukocytes in the urine, or even nitrates. Microbiology, sputum, urine, intravascular catheter, even catheter tips for microscopy and culture are necessary. Wound surgical sites and body fluids also are necessary for evaluation. And we do imaging based on the targeted site, this site that we suspect is having the infection. Routine microbiologic cultures, including blood, urine, and culture, should be obtained before starting antimicrobial therapy. And intravenous broad-spectrum antibiotics should be initiated within the first hour of diagnosis. High-risk patients, especially patients with multi-drug resistant organisms, should have at least 2 antimicrobials instead of 1 with a gram-negative cover. And for patients with low risk of multi-drug resistant organisms, 1 gram-negative agent is enough, not 2. Every hour of delay of antibiotics increases mortality by at least 7.5%. And broad spectrum can now be narrowed once the sensitivities are identified or if there are clinical improvements. Treatment duration has been debated whether short-term or long-term treatment, but 7 to 10 days is adequate for most serious infections, and longer courses may be appropriate in patients who have a slow clinical response. They have undrainable foci of infection, or maybe fungal viral infections or immunologic deficient patients, including neutropenia. And the escalation of antimicrobial should be assessed daily. Empirical antifungal therapy is needed for high-risk patients like HIV and AIDS patients or cancer patients that are on immunosuppressive therapy. There are no recommendations on the use of antiviral agents, and the prompt removal of possible sources of infection is a best practice statement by the Surviving Sepsis guideline. Procalcitonin level should be used to support the discontinuation of antimicrobial. It should not be used to indicate whether antimicrobial should be started or not. Hemodynamic support in these patients, all patients requiring vasopressors should have an arterial catheter for invasive blood pressure monitoring as soon as possible. And the choices of the vasopressor is to achieve a mean arterial pressure of at least 65 millimeters of mercury. The first line is noradrenaline or norepinephrine that is given at 0.05 to 0.5 microgram per kilogram per minute, although more studies have been done to show that it can be given to as high as 1.2 microgram per kilogram per minute. And it is important to note that norepinephrine as first line is because it improves the coronary perfusion and increases the atrial diastolic pressure. Also, it also improves the myocardial contractility and the cardiac output, and it has a very low effect on the heart rate. It has also low adrenergic effects on the patient. The second line is vasopressin that is given up to 0.03 microgram per kilogram per minute. And vasopressin is given because it can be added with norepinephrine, because decreasing doses of additive effect of vasopressin and decreased dose of noradrenaline reduces the side effect of adrenergic overload. Dobutamine also can be used in these patients that are persistently hypoperfused despite fluid resuscitation and vasopressor administration. But it should be noted that epinephrine is third line. However, epinephrine has the disadvantage of a high adrenergic load on an already septic patient. Also, there is a recommendation against the use of terlipressin for septic shock. Other ionotropes can be considered depending on the patient's hemodynamic status. This is a table of vasopressors that can be used in the management of sepsis. For patients that are very critical, those that move into hypoxemic respiratory failure, the use of high flow nasal cannula is recommended, and they can receive as high as 60 liters of oxygen. But there is no recommendation on whether invasive or non-invasive ventilation should be used in them. Also, mechanically ventilated patients for sepsis-induced acute respiratory distress syndrome the lung protective strategy should be used in them. And this includes use of a low tidal volume of 6 mL per kg as against the 10 mils or more than 10 mils per kg that was previously advocated. The plateau pressure should be kept at less than 30 centimeters of water. PEEP should be applied to avoid alveolar collapse. Pressure-controlled ventilation instead of volume-controlled ventilation will reduce the risk of barotrauma and help in the recruitment of distal alveoli, preventing or treating atelectasis in the process. And 30 to 45 degrees bed elevation will limit the risk of aspiration and prevent development of ventilation-associated pneumonia. In patients with severe ARDS, recruitment maneuvers should be considered, including prone positioning for more than 12 hours daily, and they may also be referred for extracorporeal membrane oxygenation. The glycemic control should be aimed at 6 to 10 millimoles per liter. A tight glycemic control is shown to not be beneficial in them because it can tilt them to hypoglycemia. And insulin infusion should be commenced when two consecutive blood glucose levels are more than 10 millimoles per liter. The blood glucose level should be monitored every 1 to 2 hours until the glucose level and the insulin infusion rates are stable, and then 4 hours thereafter. IV omeprazole 40 milligrams daily has been proposed as a stress ulcer prophylaxis in septic patients, and low molecular weight heparin is useful more than unfractionated heparin for thromboembolic prophylaxis, then mechanical thromboembolic deterrent, the use of the compression stockings can be used for them. Intravenous sodium bicarbonate in severe metabolic acidemia and acute kidney injury is necessary because it is shown that sodium bicarbonate can decrease the progression of acute kidney injury. And renal replacement therapies should not be done routinely for patients that are septic. There should be clear indications, the usual indications that apply to patients that will have renal replacement therapy should apply to them. Intravenous hydrocortisone can be given where there is refractory hypotension, and there is a strong recommendation against the use of intravenous immunoglobulins or vitamin C. Early enteral feeding, defined as commencement of feeding within 24 to 48 hours, should be made in this patient. They should commence feeding early. And when do we transfuse these patients? Packed red cell transfusions are indicated when the hemoglobin is less than 7 grams per deciliter, except in acute hemorrhage or in patients that are having acute myocardial ischemia, when a trigger of a hemoglobin trigger of 8 grams per deciliter is reasonable. We should also consider prophylactic platelet transfusion when the platelet counts are less than 10 billion with no apparent bleeding, when they are less than 20 billion with risk of bleeding, or in a patient that is actively bleeding, the count should be more than 50 billion. Monitoring of septic patients. Failure to improve or deterioration at any stage should prompt a thorough reassessment of the patient. Airway, breathing, circulation, history, examination, and investigations should be done all over again. The signs of deterioration will include persistent or worsening tachycardia, persistently elevated or swinging temperature, a rising white blood cell count and C-reactive protein, hypotension or increased requirement for vasopressor drops to maintain the same blood pressure, deteriorating renal output, deterioration in level of consciousness, deterioration in respiratory function are all indices to show that the patient is not doing well. I will just mention a word or two.
Dr. Udo, try and round up, please. Thank you.
When anesthetizing patient, septic patient, it is pre-run for a few hours before surgery. It is important to note that at any point a patient can decompensate and the patient can be lost in the process of anesthesia. So a trained assistant or a second anesthetist may be considered to be present, and a hypoxic patient should not be left attended to. Wide bore intravenous access should be secured in this patient, and in shocked patients, intravascular volume pre-induction should be aimed for using clinical rates like heart rate, blood pressure, and capillary refill time. I'll look at the complications. These are complications that are related to intubation and mechanical ventilation, which may include ventilator-associated pneumonia, pneumothorax, difficulty weaning from the ventilator, hospital-acquired infections like cellulitis at the site of cannula insertion, urinary tract infections, blood and blood product infections, complications that are secondary to immobility and severe illness, peripheral nerve palsies, critical illness, neuropathy and myopathy, even drug-related complications. Patients that are on long-term aminoglycosides may end up with ototoxicity and nephrotoxicity. Time will fail me to go into COVID-19, but the long-term outcomes and goals of care will be to discuss these goals of care and prognosis with the patient and caregivers, and also to reconcile medications at both the ICU level and at discharge, to have discharge plan, which include follow-up, especially for those with complications. And also, there is a strong recommendation by the Surviving Sepsis campaign that for adult survivors of sepsis and septic shock, assessment and follow-up for physical, cognitive, and emotional problems after hospital discharge is necessary. There are a whole lot of ways to prevent this infection, and it starts with hand washing, use of single-use equipment, disposable apron and gloves, control traffic, the use of isolation rooms for suspicion cases where we are suspecting to be septic, good nursing care, and even physiotherapy. In conclusion, sepsis is a life-threatening organ dysfunction with high incidence of morbidity and mortality, and a multidisciplinary approach is necessary to its management. Early recognition and treatment of sepsis can significantly reduce mortality, and the goal-directed therapy is the best practice standard. This is the typical patient in an ICU that is on a ventilator and is being managed for sepsis. Thank you for listening.
Okay, we'll thank Dr. Udo, our presenter, very much for such an elaborate presentation. There are some 1 or 2 questions in the chat box, which I'm going to read out for him to try and attend to. If any of us have any question, you can do so by raising your electronic hand and you'll be recognized to ask your question. Thank you very much. So, sir, the first question here in the chat box is, please, what are the reasons against the use of vitamin C in septic patients?
All right. So vitamin C have not been proven to show any significant benefit. There have been numerous studies that have been done. Initially, people were trying high-dose vitamin C for septic patients to see if they will have better outcomes. But it was not proven to have there was no difference in outcome between patients that were on vitamin C and those that are not. So because of this, vitamin C is not recommended to be used in patients with sepsis.
Okay, thank you. Sorry, I forgot to mention, at any point during the question and answer session, if our senior moderator will have 1 or 2 things to add, you can step in and make your contribution, Thank you very much. The second question in the chat box is, please, what is the role of thiamine, steroids, and calcium in septic shock?
All right. The role of thiamine, calcium, and what, please?
Thiamine,
And
steroids, and calcium.
okay. Okay. So steroids is used for refractory septic shock. The steroids is used for refractory septic shock. The reason is that in patients with septic shock, there is a possibility of them having adrenal insufficiency. And when this occurs, steroids will decrease, steroids have been shown to decrease the time to recovery. It has been shown to decrease their time to recovery, but overall, it doesn't have any impact on the management of septic shock. It has been shown to decrease the time. However, thiamine and calcium have not been shown to have roles in septic shock. So thiamine and calcium, they have not been shown to have roles in septic shock. So because of that, they are not used in the management of septic shock.
Okay, thank you.
So if I may have to comment, meta-analysis that was done concerning the surviving sepsis bundle 2021 did not show any evidence of improvement in outcome concerning thiamine and calcium. So it does not recommend thiamine, steroids, calcium at all. The only steroid it recommended was hydrocortisone, 200 milligrams daily. And that should be given only after fluid resuscitation is done with vasopressor support. And then we still have refractory hypotension in the case of sepsis. Otherwise, thiamine, calcium, and steroids are no longer recommended.
Okay, thank you very much, Ma, for that input. The next question is, how do you treat septic emboli?
Okay, the treatment of septic emboli is treated based on the components, sepsis and the embolism. So we merge the two together. Same thing that we do for sepsis, the institution of the 1-hour bundle and other management that follows, that's the same thing we'll do. However, for the because the patient has an emboli, this patient will be admitted into the ICU. Monitoring will be done, and if we detect the cause of the emboli, which is likely sepsis, and try to stall it, we try to stall the progression of the embolism. I don't know if my seniors have more to add.
Okay, thank you. We'll try and be a bit faster now. The next question says, could you shed more light on why sepsis definition applies more to developed compared to less developed countries, and what is its significance?
Sorry, can you take it again?
Could you share more light on why sepsis definition applies more to developed countries compared to less developed countries, and what is its significance?
Okay, so not the definition does not apply. The definition does not apply more to the developed countries. However, the guidelines apply more. And this is because there is a paucity of resources in the low and middle income countries for the management. There are centers in the low income countries where there are no facilities to even measure a serum lactate assay. So in as much as some of those, they can apply some of those guidelines, they cannot apply all of it. They can only pick some and have a high clinical index of suspicion for the management of sepsis.
Thank you very much.
Because of this, like that there was a study that was done in the Jos University Teaching Hospital where the mortality rate was as high as 53%. That was in a teaching hospital. You can imagine what will happen if we are doing a study in a village or maybe in a primary health care. where they don't have the facilities and they can't even transfer the patient. Can imagine the mortality rate there.
Okay, thank you very much. The next question is, can you give examples on how to combine vasopressors and ionotropes in septic shock? Maybe just 2 or 3 examples would be okay on the combination of vasopressors or ionotropes.
Okay, so we can start with norepinephrine. We can start with 0.05 microgram per kilogram per minute for the patient. That would mean when we start and then we monitor, can step it up to 0.1, 0.15. And while we are on norepinephrine, if we don't have significant response, then we can add vasopressin at 0.2 microgram per kilogram. So can be doing norepinephrine at 0.15 and doing vasopressin at 0.3 microgram per kilogram per minute. Also, where vasopressin is not available, can commence norepinephrine, which is widely available, at 0.05, step it up to maybe we'll get to 0.2, 0.3 microgram per kilogram per minute, and then add epinephrine. However, we should know that the epinephrine would increase the adrenergic side effects, tachycardia, tachyarrhythmias, and even possibly the blood lactate levels may go up when we are doing that.
Okay, thank you very much. Probably we'll look
Sorry,
up
can
more
I also
examples.
add?
Yes,
We
ma'am.
can also combine, if where you don't have vasopressin, you can do norepinephrine with dobutamine. Dobutamine has both beta-1 and beta-2 receptor agonist effects. So it will help with cardiac contractility. It can also help with if the patient has cardiac dysfunction. So if you combine dobutamine and norepinephrine, it can also help to maintain the patient's MAP above 65 milliliters of mercury, which is what we are aiming for in sepsis.
Okay. Thank you very much for that contribution. The next question quickly is there any benefit with the use of ulinotripsin in sepsis?
Sorry,
Hello,
please, we
Dr.
can't hear
Odoi.
the moderator again.
Ma, can you hear me now?
Yes, we can hear you.
Okay, I said the next question is there any benefit with the use of ulinotripsin in sepsis?
No, there's no benefit with the use of ulinotripsin in sepsis. So, in fact, there is no much data on the use of ulinotripsin in sepsis. For more details, for more trials to be done for the benefit.
Okay, thank you very much. Next question, that you should shed more light in the fluid aspect, because you said we don't use the 30 ml per kg, but neutral. What do you mean by neutral?
Okay, so we don't use the 30 ml per kg is arbitrary. Patients that have renal impairments, cardiovascular impairments, using 30 ml per kg for them will tilt them to organ dysfunction. The concept of fluid tolerance and fluid responsiveness has been used to guide fluid therapy in sepsis. So the fluid therapy should be individualized rather than using a fixed 30 ml per kg. It should be individualized. And then the fluid responsiveness should guide us. The dynamic parameters are what should guide us on whether someone is responding or not. So we can do a passive leg raise. We can do a passive leg raise when we are administering fluid to the patient. We can also, patients that are ventilated can also benefit from an end expiratory occlusion test, which we can just pause expiration for 15 seconds to see if there will be increase in cardiac output and all that. So those are the dynamic variables, and now what what is being used for the treatment of fluid, for the fluid management in sepsis, and that is in line with the current era's criteria.
Okay, thank you very much. I have two hands raised here, so I'll quickly ask them to ask their questions. Dr. Arinola Sanusi, can you be brief, please? Thank you.
Right. Hello, thank you. Well, I'm Arinola Sanusi, Associate Professor of Anesthesia, UCH.
Thank you.
Well, I think that's a very comprehensive presentation, and I want to congratulate the speaker. One or two things you mentioned. I'm surprised you didn't talk about dopamine at all. It's not recommended in sepsis, okay? But we know that commonly most of our ICUs we have dopamine all around. I expected that you should say something about it. It's not a first line drug, neither a second line drug. And the simple reason is that most septic patients already have severe tachycardia. So dopamine, once you start dopamine, the tachycardia increases, tissue perfusion is less, and so on. So it's only in extremis where in this environment where you can't just find anything else that you might want to think of that. So I think we should take that, keep that at the back of our mind. We shouldn't be running for dopamine in a patient with sepsis. I thought I should mention that. Somebody mentioned vitamin C, and I was happy that someone has discountenanced that, and that's because of the meta-analysis which was done some 3 years back, because a lot of people jumped on board and everybody was giving high dose vitamin C. But meta-analysis showed that it didn't actually improve, survival. So that has been discountenanced. A lot of drugs keep coming up, over the decades. So it's actually difficult, to say this is the one that works or not. But at least there are standard regimen, and I think we should stick to that. And I put something on the chat box that please, when you are presenting in this environment, you should try and use local pictures. We have many ICUs that we are managing patients, that are comprehensively monitored. So let's not go and look for European or American picture when we are doing a local presentation. And it also helps us when we go to international meetings, present your own environment. Thank you very much.
Thank you very much, ma, for that contribution and input. We are grateful, ma. Quickly, I'll call on Dr. Olafimian Tomori.
Good evening, my chiefs, my teachers, and my mentors. I want to thank you for the presentation. I have a challenge, and it's about a question I ask. We are having recurrence of patients coming down with septic emboli, and it's not just an emboli to the lungs or to any. They come in and refer to our center, and sometimes GCS is 3. We intubate, we start inotropes. Oh, then you notice that their fingers start becoming gangrenous. We once had a patient, and it's from septic abortion, referred from a multi-center to our center because of funds, and we ventilated. We had to amputate the hand and the leg of the patient because the emboli continues and the gangrene continues. Then we have a child recently that had the same effect. We lost the child in the process. And that's why I'm asking that what management protocol, especially for our teachers to give us what we can do in handling such case. And somebody suggested the use of urinary statin, which somebody has urinary trypsin, same drug, and is an immunomodulator and clears cytokines and all of that. We've not tried that, but we just need something to stem this recent occurrence. And that's why I'm asking question. Thank you very much.
Dr. Udo, can you attempt responding to him?
Yes. So we like I had responded earlier. Septic emboli is conservative. The management of septic emboli is conservative, just like we manage sepsis that is how we approach septic emboli. There have been no drugs to show that there have been improvements in outcomes. So we can't state any drug that we can use for the management of septic emboli. But we should, and apart from that, the main problem with septic emboli is the progression of sepsis itself to now cause the septic emboli. So it is the Surviving Sepsis campaign guidelines to be followed in the management of sepsis, while we look at the entity, the emboli as an entity, and manage it also conservatively.
Okay, thank you very much. I'd like to thank our presenter for such an elaborate presentation and the good responses to most of the questions. There are a few other questions in the chat box, but our time is quite fast spent. So we'll collate the questions, and when he's sharing the slides, he'll attempt to answer some of the questions before sharing the slides with us. At this juncture, I would like to call on my senior, my co-moderator, who is my very senior colleague, to come and add one or two things if there are, before we hand over to the NSA representative. Thank you.
Thank you very much. Good evening, professors, consultants, residents, and everyone here present. I was actually sitting beside the presenter, so some of the questions that you answer were actually working hand in hand. So, but as a way of summarizing this topic, sepsis already we know poses a major healthcare burden globally, and it's even worse in low-resource countries such as ours. He has talked about the pathophysiology from tissue invasion of the microorganisms to endothelial damage, release of pro-inflammatory cells, and then to coagulation, coagulopathy, and eventually multiple organ dysfunction and multiple organ failure. He has gone through definition of sepsis from 1992 to 2021, which I'm not going to go over it again. He has told us the diagnosis, which he talked about the clinical features, and then from blood culture, serum lactates greater than 2 millimoles per liter, you can make your diagnosis. He talked about the screening tools that we shouldn't use. It's recommended that we use more than one screening tool for diagnosis of sepsis. And then the management of sepsis, he has talked about the initial resuscitation, source control, that's infection control, ventilation of these patients, maintenance of hemodynamics, additional therapies, and then follow-up. A lot has been said throughout his presentation, which was very detailed. And the questions that came up, I would want to say that the researches I did, it's still not recommended that we use vitamin C, thiamine, steroids, calcitonin or calcium as part of management of vitamin C. Procalcitonin should be used to de-escalate antibiotics in the treatment of sepsis, but it should not be used to initiate it. And then what else? For septic embolism, there is no drug treatment, no drug of choice presently. We are to manage it conservatively as a multidisciplinary approach in which management of sepsis itself is. So thank you very much.
Okay, thank you very much, Ma. I would like to call on our senior colleagues, our teachers that are present with us, if any of them have anything to add to this presentation.
Hello. I just want to make a comment on this emboli and gangrene. There's no specific drug, but many centers have tried using local treatment, it's not something we have come across in our environment here. They use leeches. Okay, leeches are small, tiny animals. put leeches in, in a bag, and then, wrap it around the, the leeches are put in a bag, and then the end of it is wrapped around where the gangrene is, okay? And the basic principle is that the leeches can actually, leeches suck blood, okay? And in the principle is that in trying to suck blood, they can open up vessels that will supply more blood to those digital ends. Now, I think it's something that we can check up how well it works, but have seen that before. Thank you.
Yeah, thank you very much, ma'am. Okay. I'd like to thank the presenter and all of our colleagues and senior colleagues who contributed to the success of this presentation. At this point, I would like to hand over back to the NSA representatives. I'd like to call on our president-elect, Dr. Kalu, for contribution and any final remark. Thank you very much.
Thank you very much. Thank you very much, our resident representative, for a good coordination of this. Thank you very much, the presenter and the resident, both the resident and the consultant moderator. I want to thank everybody for joining. I thank Professor Sanusi very much for all the contributions he has made. And I thank you very much for joining the meeting. There are other senior colleagues that are here. I believe our president is still on the call. So as I finish, I'm sure he would like to say a few concluding remarks before we close out on this. So I want to thank I think I saw Dr. Elumelu, I saw Dr. Odonkwak, I saw Dr. Jauro, and a few, I think I saw Dr. Adeshion, and a few others. I thank you all very much for finding time to contribute. And I believe everybody who joined the call has learned one or two things that will help us in managing our patients better. And for our residents, I believe this will also contribute to your success in your exams. So I want to remind us that our residence academic series hold every first and third Tuesday of the month. And then bi-monthly, that is every other month, we have the general webinar for NSA. I'm sure most of you joined the last webinar and it was very interesting. For those who cannot join us live, a few days after presentation, we usually put them on our YouTube channel, and these are very good resource materials. Please find time to listen to them and also give us a feedback as we continue to improve. Remember to pay your NSA dues. I think the details are on the chat box of this group and also on the NSA page. Once again, thank you very much for joining. And I hope our president is on the call. Please, President, if you're still here, kindly unmute and make a few concluding remarks. Thank you, everybody.
Thank you very much, dear President-elect, for this opportunity. I'm so sorry I joined late and I completely forgot doing something else. I want to first comment on what Professor Shanusi said about these leeches. I remember we have someone here in BUK, I think, who employed this technique. I think he specialized in that. It was well celebrated. So what I would do, I will contact him and see what he has on it. And then when the link to this presentation is ready, we can share along with that so that we will be better educated. Just to throw more light on what Professor Shanusi said about those leeches. Someone tried it here in Kano. I think it's very much so I will contact him. I want to call, before I conclude, I don't want to ask if Professor Lebe is on the call because I call her. I don't know whether she's the one that has iPhone. If she's around, she can unmute and talk. Otherwise, I call on the, hello? Okay. Our PRO, please unmute and say something before I conclude.
Okay.
Thank you.
Good evening, everyone. Thank you, our president, and for giving me this opportunity to speak. And thank you, the VP-elect, for this wonderful webinar series that is being organized. And to the presenters today, I also want to appreciate you and thank you for the wonderful presentation and moderation. I just want to remind us that our social media handles are all there on Instagram, on Twitter, and on YouTube. And as our VP-elect have said, once these presentations are over, we try as much as possible to upload them to the YouTube channel as a very good educational resource for us to use subsequently. We are all encouraged to pay up our NSA dues as soon as possible. This will help us to serve you better and also make the association function much more efficiently. The details are pasted on the chat box and will also be on our NSA platform and also all other platforms that anesthetists in Nigeria are in. So thank you once more, and I wish us all the best. Thank you.
Hello. Hello.
Yes.
Hello. Good evening. This is Professor Legbe.
Oh, okay, ma.
I've been
You
having
can
some
speak, ma, before I conclude. Yes,
I've
ma.
been having problems with my phone, but I had most of the things. The only
Okay.
question I wanted to ask was the role. I had somebody talk about the role of giving steroids in the management of shock, septic shock. Is it a new thing or what? What is the basis of it? What will be the reason for adding steroids at any point in the management of sepsis? I couldn't figure out how that came in. What was the what are you trying to achieve by adding the hydrocortisone to the management? I couldn't fathom that. If you can explain that for me, what is it going to do? What effect are you expecting by adding it?
So if the presenter is still around,
Is the presenter still on? If not, don't worry, maybe another time.
Okay, but this is something we have to ponder because this is a residence presentation, so I think we can all go and look for it.
Okay.
Yes, ma'am.
Well,
Somebody has posted something here on the chat box. Maybe let me read it and hear what he said. Where is it now? Just a moment. Someone just posted something. The steroids are thought, that's from Dr. Elumelu. Steroids are thought to mitigate sepsis-induced adrenal hypofunction.
Say that again.
Steroids are thought to mitigate sepsis-induced adrenal hypofunction. In other words, sepsis tends to cause hypofunction of the adrenals. So the steroids are thought to mitigate that.
Okay.
Yeah.
All right.
That is
Thank you.
So we still can look up on this for us to all benefit. Thank you very much, ma. And sorry for
congratulations to the presenter and joining this conversation helps keep me out of my brain trying to sleep and going.
Yes, and I apologize for joining. I joined very, very late doing some NSA work. I just forgot.
Okay.
So
congratulations, everybody. Keep it up.
Thank you, ma'am.
It is
Thank
well.
you, ma'am.
All right.
Yes. So Congratulations to the Education Committee led by Dr. Quinnet Kalu, the President-elect, who is the chair of the Education Committee, the presenters and the presenter and the moderators. I'm so happy that we are doing this with increasing regularity. The residents are settling in. The aim is for you to empower you to be able to talk, and hopefully it will improve your practice and also for exams. So please feel free to send in your contribution, how to improve on these things to the education chair or to any of the ESCO member. And you also have the resident rep, who I have to thank, especially because he's been working very closely with the chair education committee. So congratulations to you all, and please let's keep it up. Thank you very much, everyone. I will see you. We'll see you next time. Bye for now.
Hmm? What are you doing? Your homework? You